The focus of the DVD you are watching is soft tissue management, and we do this to improve the functional and the aesthetic results of our implant cases. How do we get these fine aesthetics? Well, we work with components, and we have many components involved in the complete picture. And when we look at the end result, we have two groups of components we want to work with. It's the implant, the abutment, and the crown. And this we can call our hardware, because we buy these components, like the implant, or we let them fabricated. And this is the second group of components. It's the bone, the soft tissue, and the neighbor teeth, and we can call this our biological challenge. This is the most interesting part for the clinicians, I think. Bone. Let's start with bone. Can we recreate bone? Well, this is the good news. We can recreate bone. We have this technique called the guided bone regeneration. We can do it in a horizontal and in a vertical way, and it's driven by the prosthetic planning and by the biology of the patient. So you can see here 2 implants are placed partly outside the bony envelope, and 8 months later we can see the result of what GBR can do for our cases. So we can conclude that GBR brings back the bone to our implants. You see it from an occlusal view. The drilling was done first. Implants were placed. We have stable implants. Now we place a bone graft covered with a membrane, a non-resorbable membrane. And here we have the results 8 months later. Lateral view, the implants partly outside the bone. The bone graft is placed. You see the bleeding, indicating that osteogenetic stem cells are coming out of the underlying bone, because I made many perforations before placing this bone graft. And the white layer on top is the membrane. The membrane has to be fixated. You can see that there is a certain space between the natural tooth and the membrane, and we do this in order to avoid contamination through the sulcus around the teeth. So this is an important detail. And here we have the result of the regeneration after membrane removal of the same 2 implants 8 months later. So we can go from here to here. The implants are all covered up with newly formed bone, and this takes time. The minimum time is 6 months. In some cases we wait up to 1 year. Let's look at the shape of the bone, the 3-dimensional shape of the bone. If we have a flat bony profile, that means also something for the soft tissue profile. So what is the relationship between soft tissue and bone? Well, as a guideline we can say that the soft tissue roughly will follow the bone. So if we have a situation like this, even if we don't see the X-ray, we can guess that the bony profile is flat. And this is the case when we work with implants, which will be placed in a flat bony crest. So we have to be careful by promising papilla to our patient in a case like this. So if we have a flat bony profile, you probably end up with a situation as you see here in this slide. The beauty of nature is very difficult to mimic with an implant-supported prosthesis, because underneath what you are seeing here is a very complex 3-dimensional structure, and this is giving us the full-size papilla we are looking at right now. And this is this 3-dimensional structure. We have a scalloped bony profile, and we have a bony peak in between the 2 natural teeth, and this is supporting the papilla. Can we recreate this interdental peak also between implants? Well, we can do it. It's very difficult because we work in a very small area. You can see here the bone graft taken from the nasal spine, the fixation with a mini screw, and a membrane is draped on top of this bone graft. You can see here the result 8 months later. So we bring the bone within an area where it's able to support the papilla. So we go from here to here. So we can do this, but this is very advanced GBR because it's vertical ridge augmentation in a very small area. Is this bone stable? Well, I don't know. I don't know if this bone will stay here or not. And sometimes it does, sometimes it doesn't. We also need soft tissue in order to complete the case, and we will going to be looking into that further. So as a first conclusion, we can say bone is our soft tissue framework. It's our supporting structure for soft tissue. What about soft tissue? The importance of soft tissue. Of course, we need both. But why is soft tissue so important? Well, I found out at least 4 reasons. And the first reason is that if we have an optimized soft tissue seal, it will help us to preserve the underlying bone. And I can point out also to the paper published by Benghazi. So we have the preservation of underlying bone. Other reasons are also that we need the space for creating an emergence profile, because we want our implant-supported prosthesis look like natural teeth, so we need to emerge from the soft tissue with a tooth that has more or less the same shape as a natural tooth. And we also need this space for the biologic width. So the biologic width, what do we mean with biologic width? Is this difficult? Well, the biologic width is basically nothing else than an organization of different layers of tissues. If we look to an implant-supported prosthesis, and you cannot see the implant, but it's here, it's there in the picture, we can see there's some bone loss around this implant. And this is normal because biologic space has developed in this area. And if we look into that a little bit closer, we can see if we go from coronal to apical, the sulcus epithelium on top. Then we have a layer of junctional epithelium, and the trick is that nowhere in the body epithelium can touch directly the bone. So we need space between epithelium and bone for connective tissue. I think the main reason for that is that the epithelium doesn't have its own vascularization, and therefore it will need always a layer of connective tissue underneath. So this is how the biologic width is layered up. And there is a horizontal and a vertical component in the biologic width. And you see here the vertical component and the horizontal component. And these two components really depend also a little bit on the implant design and on the structure of the surface in this transmucosal area. The last reason is that we need also thick soft tissue in order to create pink aesthetics. Pink aesthetics can be a root profile, soft tissue profile, or a pontic site, as you see here. And we need that in order to get an aesthetic end result. So you see here these 4 pontics, they look like natural teeth that emerge from the soft tissue. And we can only do this if we have thick, soft tissue in this area. Soft tissue aesthetics. It's important, quality is important. With quality I mean thick keratinized tissue, and quantity. The quantity basically means that we never have enough. It's much easier to remove soft tissue than to add soft tissue into a site. And the thick periodontal biotype works best. Well, there's good news and there's bad news. The bad news is that we only have in roughly 15% of our patients this Szkw biotype as a starting point. So it's thin or medium biotypes in most of our cases. The good news is that we can recreate the Szkw biotype. So we can boost the biotype, and that will be the slogan for this DVD. We can do this in different stages. Before we go over that, I first want to show you how a periodontal biotype looks like. This is the Szkw periodontal biotype. You can see thick tissue, flat and wide papilla, square teeth, and this is the Szkw biotype. The thin biotype we are looking here now, this is a nightmare for most of the dentists who have to work on these teeth. You can see there are already some areas with recessions, like the canine, and the papilla are very narrow, thin, and we have triangular teeth as well. So this is the thin biotype. The good news is that we can boost this biotype during different steps. We can do this during extraction, during implant placement, regeneration, second stage surgery, and dedicated surgery. Also, orthodontic extrusion of the teeth can be a way in which we can increase the amount of soft tissue in a post-extraction site, for instance. So we will go over most of these steps in this DVD. During extraction, it's easy to add some soft tissue to the site we're going to work in with our implants. So we're going to just show you now a short video of the basic steps doing this type of procedure. We will go through the basic rules of doing an extraction with primary closure. We start with the removal of the sulcus epithelium, as you see here. We can do this before or after the extraction, depending how accessible this epithelium is. So we make a circular cut, and we are trying to do the extraction. When you make movements with a plier to take out the root, we don't like the luxation movements. We try to rotate out the tooth or the separated roots. So this is important in order not to damage the buccal bone. If we have retention of root fragments, as you see here, we have to be careful as well when we take them out. First, I'm cutting away a piece of sulcus epithelium that was left in the area. So the sulcus epithelium has been removed almost completely. You see, I'm cutting here into the root and not into the bone. That's the main thing, because we don't want to damage the bone. And now I have an entrance point for the removal of the retained root. And here you will see it comes out easily, leaving the bone intact. Now we have the clean socket, and we're gonna mobilize the borders of the socket. I'm using a mold curette for that, the small part number 2 of the mold curette, and the mobilization of the borders will make it easily to get a good adaptation with the inlay graft we're gonna place in that site. So I'm taking here the inlay graft, and I'm using a suture to remove this piece of tissue more easily. So this is also to avoid that maybe it disappears through the suction system. So here it comes out of the donor site. Just a quick and efficient closure of the donor site. I'm using some collagen and a mattress suture just to over suture this, and we don't want to lose too much time with this because we have a piece of tissue that we would like to insert in the socket. So don't lose too much time with this step. Otherwise you rather do it later. After an initial stabilization of the patch of tissue into the socket, we make more and more sutures in order to get a good adaptation. And this is basically how we do this inlay grafts. This is quite simple and straightforward to do. Good, we have seen now the basic steps in the video, and I just want to come back to the papilla protocol we have seen when I showed you the importance of supporting bone underneath the soft tissue. Well, we have here now a different variation on the soft tissue closure, and we're going to see how I boosted the biotype in this case, where I had to remove 2 central incisors. So besides the bony part, you will see now the papilla protocol in this case. The 2 central incisors had to be removed in this patient. Socket epithelium is removed. The sockets are cleaned out, and I'm tunneling right here the side. So I'm tunneling underneath the papilla and slightly buccally and palatal of the socket borders, the socket margins. And here you see the connective tissue, and I call this a snake graft because it's like a snake going into the tunnel with the head of the snake and the tail of the snake sutured on the deepitalized papilla on both sides. You can see this here and over here. And now we are going to have a look at the healing. So this is sealing off the sockets, and it's supporting also the soft tissue, because you can see after the healing there has been no soft tissue collapse. And this is important because in most of these cases we don't have the underlying bony structure to support this tissue. So if we wouldn't have done this, probably the soft tissue would have collapsed, because we went from here to here, and this is 5 weeks later, and you see how nicely the ridge is preserved in this area. So we also added keratinized tissue. To have a lot of keratinized tissue is always good, because we have to augment the area now and place our implants. 2 adjacent implants were placed. You can see here there's no interdental bone between the implants, so we're going to build that up again with a small piece of the nasal spine, some bone chips covered by a non-resorbable membrane, and the whole site is covered up. So we went from this to this level. So we are building up the interdental bone, and we can see this also. This is before the procedure, our starting point, and this is the same patient with the provisional. You see how much more coronally we are building up this site already. So we're gonna wait now 8 months, and we're gonna do some dedicated surgery to build up the soft tissue in a more extensive way. Membrane removal shows us the result of the bone regeneration, and we can see the interdental bone is towering high above the head of the implants. These are 2 replace implants, still with the external hex, which is 1 millimeter high. So you can imagine how far coronally we are from the neck of the implant with the newly formed bone. I'm going to place now 2 modified healing abutments on these 2 implants, and you can see the concavity. So I basically make these concavities to stay away from the newly formed bone, and this will help to preserve the bone. In these open spaces I create with the fixation of these 2 abutments, I'm gonna bring in now some connective tissue, and this is what you see here. And we have now some additional connective tissue in an area where we will create a papilla. So this will be the basis of a papilla, of the future papilla. There's another interesting thing, because if the implants are placed with a correct spacing of, let's say, 3 millimeters, we increase now the area between the abutments, and we can almost double it. So if we have a concavity into the healing abutments from 1 millimeter, it means that we have 5 millimeter of tissue in this area. So this will give us much more vascularization in this area by enhancing the volume between these concave abutments. This is the occlusal view. The procedure goes on with flap mobilization and closure of the site. Closure is really easy because we have made a very straight and short beveled incision in the area, so this will heal perfectly. Revascularization of the whole site is quite easy, incorporating also our 3 connective tissue grafts, and now we have a re-established vascularization in an area where we want to create the papilla. Remember, we doubled almost the volume in this area, so we have more vascularization. This is important because we know we have a scar tissue type of tissue between the implants, around the implants, and in this scar tissue there is not much vascularization, so you want to have as much as possible in order to make it survive. So I'm basically telling you that I'm treating the interdental area between the implants as a mini pontic site. And I do this because we don't have the blood supply we have around natural teeth. Around natural teeth, there are some vessels coming from the periodontal ligament going into the papilla area. So this is the blood supply that helps us, I'm talking about natural teeth, in some very small areas, like I showed you in the thin biotype. This blood supply helps us to let the tissue survive in these areas you see here between natural teeth. And we don't have this pathway between our implants. So this is why I try to enhance the volume of tissue we have to work with our implant cases. And this is how the picture looks. So we have the enhanced area, and this will be our future papilla. So remember the biologic thinking behind this build-up of tissue. You can see that I came quite far coronally because I closed my flap on top of the 3 millimeter high healing abutments, which were covered in this case. So after 5 weeks, we just have to reopen the area. You don't want to cut through the papilla at this stage anymore because the papilla is already there. So I basically use a tissue punch to uncover this. And now we can just finish the case, use in the end, after having worked with provisionals, the same concavities in our final abutments. So we work with this system, and this made it possible for us to get, in a limited number of cases, patients with a high lip line, as you see here, a good interdental papilla also between implants, working with this soft tissue protocol I just presented to you. So we are boosting the biotype also in this very difficult group of cases where we have 2 adjacent implants next to each other. And this is how we try to mimic nature with our implants. Now we're gonna have a closer look at the clinical case. You can see here there was a root fracture in a lateral incisor that has to be removed. First I had to remove also the small bridge because we had 2 crowns together, And in this case I was lucky to be able to remove both of them. So these crowns came off, and of course we're gonna use this also as a temporary. So we clean this out, and now you can see the damage on the lateral incisor. After giving anesthesia, we will see now how we do this in this clinical case. So we're gonna go again over the basic steps. Sulcular incision. I do this where I have an easy access to the sulcus. So in the interproximal spaces you might want to wait till the tooth is out before you do this. Use very small blades. Different instruments can be used. Sometimes, as you will see in this case, we will also use diamond drills to take off the last pieces of the sulcus epithelium. Now we've come to the point for the extraction. You can see here on the palatal side we have a bone defect due to the fracture. I'm using now a periotome in order to mobilize a little bit the tooth, and then we go with the same rotational movements as you've seen before in the basic steps to do the complete removal. And now you can see, if you look very closely, the fracture that was in this tooth. Here it is. It's a vertical fracture along the whole length of the tooth, and this is why there was the bone defect on the palatal side. You see it nicely in the close-up of the fracture. We start now cleaning out the socket. We can do this with different instruments. Of course, a spoon is well indicated to do this. We clean out the tissue, granulation tissue out of the socket, as you see here. And we can also use some drills, some diamond burrs, as you see here, to clean out the socket. And these type of instruments, they sometimes are good as well to remove the last bits and pieces of the sulcus epithelium. So if you use them carefully, they help you to deepitalize the whole border of the socket, because you don't want the epithelium stay in the socket. Just check over closely, and if there's something left, I take a round burr, as you see here, and the epithelium is cut back right till the border of the socket, as you see here. So a small piece left on the palatal side, as you see. And we can use also some microsurgical instruments like scissors to get this tiny piece out of the area. This is what I'm doing now. You see the bleeding. So bleeding is a sign that the epithelium has been removed. Just to stimulate the bleeding in the deeper part of the socket, in the bony part, we're gonna use some files. This is a Szkw file. It's an instrument originally made for the removal of interdental bone. This is why there are some flat sides on the side of the instruments, and they work quite well to roughen up the inside of the socket. So now the area is ready to be closed. We just keep the area wetted, and then we will go to the donor side. When we go to the donor side, after giving the first anesthesia, we probe with the needle to see where we have enough thickness to remove the patch of the inlay graft. So we localize the thick area, and we will do now the incision. Normally we will choose the size of the graft slightly bigger than the size of the socket margins. We make this circular incision with a 15C blade. Also here we will use a suture to stabilize the graft and to make it easier to remove the graft from the side. Here I'm using the 50 monofilament suture. And as you see, with some pulling and moving the inlay around, it becomes easier to work my way around the inlay and to remove it from the pallet. We try to do this partial thickness, so we leave some periosteum on the bone, if possible, of course. And if you can find the good thick piece of tissue, it will help with the adaptation to the borders of the socket. Also here, the same collagen to stop the initial bleeding. And we do this step as fast as possible. In the meantime, the inlay is put in some sterile water. And this is a mattress suture just for the fixation of the collagen sponge. So now we have the inlay and we go back to the socket, to the extraction side. And here we have the socket waiting for us. Before we close the socket, we want to create some additional bleeding. So this is why I go in with my Szkw file once more. You see, the graft is slightly oversized, and we try to find the best position for the graft into the socket. First we try to stabilize the inlay in one point where it's easy to make the first suture. And once we have that suture made, we're gonna add some additional sutures and the graft will become more and more stable into the side. So this is how we normally proceed. We start with single sutures. And we are going for the best possible adaptation of the graft, and we have to be careful not to over tighten these first sutures, because it's easy to provoke a rupture of the socket margins. There's a second one, a palatal suture, which is basically doing the same. Now we have two sutures. In total, we will use 5 or 6 monofilament sutures to close completely the socket. In the meantime, we have cleaned the existing bridge, and the lateral incisor was filled with composite, as you see here in this shot. We polished this composite and we proceed with the cementation of the bridge. So this is transformed in a temporary bridge. There shouldn't be any pressure on the tissue, as you can see here. After checking this, we proceed with the cementation. And this is the occlusal view of the site. When the cement is set, it's completely removed with some dental floss and the healing starts. We're gonna have a look now at the 1 week healing, and you can clearly see that the graft survived quite nicely. I'm introducing to you now the next patient, and this is a much more extended and much more difficult case than what you've seen till now. You can see here the situation, the clinical situation, and this patient has had in the past an accident, and the problems we are going to encounter are with the 4 upper incisors. You can see a missing papilla here, very thin tissues, overall a very thin biotype, but clinically the picture is not so dramatic. On the radiographs you can see what's really happening here. These are the 2 centrals and this is the other lateral, the one with the missing papilla. So we also have an open bite, and these teeth were reimplanted after the accident. So they got retained, and this retention due to the ankylosis caused a negative smile line in this patient. And you can see there's an open bite, an interior open bite. So we have here these points. We have a negative smile line, an interior open bite. We have a very thin biotype. Look at the tissue, very thin. And these 4 incisors have to be extracted. And in this area we have to do ridge augmentation and implant placement. So this will require a lot of flap mobilization to cover the new volume of the ridge. In a small animation we will anticipate what our plan is with this patient. The volume of the ridge will be, as you see here in the animation, so we need, in order to cover this new leaf volume, a flap design. And you can clearly see now that the buccal flap is too thin and too short. So as we have this thin tissue, we would like to thicken the buccal part with a special flap design. So this is our plan for this patient. Surgery starts, of course, with anesthesia. We are starting now with a buccal sulcular incision from canine to canine. Try to do this very delicately. because we have very thin tissue, as you can see. The blade I'm using is a 15C. In addition to this blade, we always use a round blade holder. With the round blade holder, our movements become more precise. We do this incision buccally and palatally. So we are working slowly our way around the 4 incisors that have to be extracted. Now I'm going into the side with the periotome. Start to mobilize a little bit more the flap in order to be able to do delicately the extractions, because we understood already looking at the x-rays that there might be some danger of fracturing these incisors. This is the first lateral incisor. You can see the very short roots. And you can see the external resorption which is present on the root surface of this tooth. Proceed with the central. And we are even able to have a closer look at the endodontic treatment of this tooth by removing some of the granulation tissue which is present in this area. Now we move on with the other central. And also here we have evident signs of external root resorption. And this is the lateral where we had the missing papilla. This lateral incisor turned out to have the biggest damage, as you can see after the extraction. This is quite a dramatic external root resorption, and this could have easily caused a fracture. And here we have the complete picture of the 4 incisors. We proceed now with the removal of some of the granulation tissue and the sulcus epithelium that remained present in some areas. Due to the extensive root resorption, there's a lot of tissue to be removed, but the most important thing is that we at least remove the epithelium. Removing the epithelium is vital to obtain primary closure of the site. Now we are going to try in the temporary bridge, and now you can see that there's a big gap between the bridge and the soft tissue. So this is giving us an idea about the amount of missing tissue we have in this area. So this will be our future build-up. In order to do the primary closure, we are using a template. And this template is indicating the size of the graft we would like to remove from the pallet. The pallet will be the donor side for this procedure. So the size of this template was too big to be taken out of one side of the pallet. So this is why I decided to divide the template in two pieces, and also the graft will be divided in two pieces, which will be taken out of both sides of the pallet. In order not to lose orientation, we make some markers on the template. You see the little arrows, you see the 1, 3, the vestibular and the palatal mark on the templates. So we can always put the pieces together in the right way. We transfer them now to the pallet after we have given the anesthesia, and we trace the outline of the template. In a patient with a thin biotype, it can happen that also the donor side is very thin. So we had to go here for the removal of the complete layer of the pallet after desepithelialization. You can see here the outlining. And now we proceed with the deepithelialization. And this part will be completely removed after we use the mold curette for the desepithelialization. The good thing of this step is that you can check by the bleeding of the site when you are through the epithelium. And now we start removing the full layer, and we just leave some periosteum on the bone. So this is 1/2 of the graft. You can see it matches perfectly with the template. After doing the same procedure on the other side of the pallet, we try to put the pieces together. The donor side is covered with a collagen membrane. This membrane will soak up the blood and will become adhesive. The collagen membrane is kept in place by over suturing it with some 5-0 sutures. Now we are going with the pouch preparation by using a special beaver blade, and we try to do this without making vertical incisions. After a palatal fixation of the graft, we will place the buccal portion into the pouch. Stimulation of the sockets will provoke bleeding, and here we place the second half of the graft. The bleeding is important for the nutrition of the graft. And here you can clearly see that also this graft goes into the buccal pouch. Now we can mobilize the buccal part on top of the graft by using vertical mattress sutures in the papilla area. So we try to cover up most of this graft. So by layering up the site, we create a thick biotype in this patient, just to prepare this patient for the upcoming GBR procedure. Good stabilization of the different layers is vital for the survival of the area. Now we are trying in again the adhesive bridge, which will be placed under rubber dam. After preparing the site and the two surfaces with the usual steps we use for adhesion, after removing the excess of cementum and an occlusion check, the patient is ready to go home and go through the healing process. We've seen now the possibilities we have when we have to extract a tooth, how to boost the biotype during extraction. Another possibility we have is to do the same thing during implant placement and bone regeneration. You can see an implant has been placed in the bone. There's a fenestration defect because there's a big concavity, and the bone has been perforated to get the osteogenetic stem cells out of the underlying bone. This is why you see the bleeding. On top of this bed I prepared in the way I explained you, I place now my bone graft and I protect the bone graft with a membrane. On top of the membrane we can place a connective tissue graft, as you can see in this slide. This works quite well and there is very few risks for complications. The only thing you have to be careful with is that you fixate the connective tissue graft, as I have done with a resorbable suture in this case. So this is how we can let bone and soft tissue work together to fill up the concavity you see in this case. So we went from this profile to a correct soft tissue profile by building up the concavity with both bone and soft tissue. Just to show you another example, in this case with a very thin biotype, we have a female patient that lost a central incisor. You can see the color is a little bit different. There are some problems here. This tooth had to be extracted. You can see also on the neighbor teeth the recession defects present on most of the teeth. So we placed the implant, we did a huge bone graft, and we tried to cover at the same time with a connective tissue graft the recessions, and we tried to create at the same time some more volume and some thicker tissue also in the area for the implant. So we are basically over contouring the site, as you can see in this occlusal view. And now we close up the site, and this is after healing and second stage surgery. So if we are able to create thick biotypes in patients with thin biotypes, we are just very close to getting the aesthetic results we want to achieve in our patients. So you can here clearly see the soft tissue profile and the correct aesthetic parameters on these teeth I just have been rebuilding. So the central is placed on the implant, and the recession on the lateral has been completely covered with the connective tissue graft. So we get a stable and harmonious soft tissue profile. So this is the way we can work with soft tissue also during implant placement and GBR procedures. We are coming across the possibility we have during second stage surgery to improve the biotype as well. During second stage surgery, we can make 3 types of incisions: the straight incision, the U-shape, or the O-shape incision. The flap design we apply on most of these procedures is partial thickness flaps. Let's start with the U-shape. When we are trying to make a U-shaped incision, it's better to use a template. You can see the template here. 2 implants are going to be uncovered, and we make a partial thickness flap. This is a little bit more complex as the straight incision we are going to look into afterwards. But if you use the template, things get easier, and you can uncover the implants in the way you see here on this slide. In the area where we have thin tissue on the palatal side, we are running into the risk of inducing some extra bone resorption on the palatal side of the implants. I'm referring this to the paper of Berglund and Linde, which was published in 1990, and they have demonstrated that in the area with the thin tissue, you can get some additional bone resorption, as you see right here. So in order to avoid this undesired bone resorption, I modified the U-shape into an O-shape. The O-shape design will uncover the implants, leaving thick tissue 360 degrees all around the uncovered implant. This flap design is demonstrated in the following case, where I had to uncover 3 implants. You can see distally one of the implants has been perforating already the non-keratinized tissue, and the other 2 implants are present under non-keratinized tissue as well, but they are still covered. The flap design starts by tracing the 3 circles, the 3 O's, on the palatal area where we have thick keratinized tissue. The inter-axis of these circles should be the same as the inter-axis between the 3 implants. We make now a partial thickness flap design with an incision starting from palatal towards the crestal area, as you can see here. If we come to the crestal area, we are making some vertical incisions, and we work in the opposite way to complete the partial thickness pedicle we can see in this slide. Now we remove the cover screws, we take out the circles, and we fixate the flap in the way you can see right here. Suturing can be complex, and I use a microsurgical technique to get the optimal flap adaptation to the donor bed we just prepared. Now the healing will show you that we created all around these implants nice and thick keratinized tissue. So this is the O-shaped flap design, and this is how we can get the biotype back to what we want to have. You can see here the case with the completed prosthesis placed on the implants. Now, as the last solution, we're gonna look into the straight partial thickness incisions. In a patient where all the teeth had to be removed, we decided to go through a full denture, as you can see here, into an implant supported prosthesis in upper and lower jaw. To do that, I placed 14 implants in this patient, as you can see here. At time of implant uncovering, the patient had been wearing for 6 months a prosthesis sitting on these 8 implants in the upper jaw. Very thin tissue was present, and this is why we had some perforations, and we wanted to enhance the biotype in this patient. We're gonna present now the second stage surgery, uncovering 8 implants. So we see most of the implants are under the non-keratinized tissue, and the idea is to do a partial thickness flap by removing the keratinized mucosa from the palatal area towards the buccal. So I'm pointing out now where the implants are, and you can see clearly that some of them are perforated and most of them are completely under the non-keratinized tissue. I start with my partial thickness incision as far as distal as possible, because when we move the flap from the inside to the outside of the arch, we need some extra length. So this is why I start far behind the most distal implant. I'm moving now in front of the incisal foramen, and this is a delicate move with the blade, so you can see me passing on top of this foramen. We do the other side of the incision, and you can clearly see also here that the incision starts far more distally than the most distal implant, and I connect both incisions. The vertical release incision shows us the direction in which we will move the flap later into the surgery. So we'll move the flap buccally and forward. Now we can see that I started completing the partial thickness flap, starting from the palatal till the area where the bone curves away. And we have to be very careful not to perforate the flap. So this is why I like to use vertical incisions to go in from the opposite direction, working towards the point the bone is curving the most. So this is a central incision. You can see how I go into the incision and work from apical to crestal. So this is how I connect the incisions in opposite directions. So we go from apical to crestal and from palatal to crestal. We do this in order to avoid perforating the flap. You cannot work along a curved line, so this is the reason. We check if there are any retention points at the basis of the flap in order to be sure that the flap will sit stable in its new position. We are doing now exactly the same on the other side. So you see here nicely how I go in the vertical incision and work towards the crestal position. Connect both partial thickness flaps. And this is how we can do in a controlled way a partial thickness flap over such a huge area. This is what you see right now in this shot. We clean the area, we check if there are any minor corrections to be made, and now as an additional thickening of the biotype in the aesthetic zone, we're gonna take a bilateral connective tissue graft by working with one incision parallel to the palatal mucosa into the donor side. So we go down, let's say 2/3 on the palatal ramp into the donor side, staying parallel to the mucosa. The second incision, that's what I'm doing now, runs parallel to the bone. So we have two parallel incisions which I'm connecting right now in this moment. So connecting these incisions, it becomes really easy to remove the connective tissue from the donor side, and we will bring this into the new position, which will be the aesthetic zone. Of course, this is only half of it. We do this also on the other side, and this is what we could call, after removing the second tissue graft, the catch of the day. So we are connecting now healing abutments on the implants, which will help us to stabilize the connective tissue and the different layers of the flaps we have prepared now. The connective tissue is a free graft, so it needs to be stabilized, and this is done with a suture starting from the palate. In the donor side, I place some collagen material just to stop bleeding and to make healing a little bit more comfortable for the patient. And now you can see that the different layers are interconnected by a 5-0 monofilament suture. So I like to do the single sutures, normally mattress sutures, connecting the different layers, and this will be done by looking for anchorage and by eliminating movement. Any type of movement of these different layers will prevent good healing. So this is how we work our way along the arch, and this is how we fixate the different layers. You can see clearly the situation before and after this surgery, and on the right hand side you see how much thicker the whole area looks after the build-up. At the time of impression taking, you can see the transfers on the 8 implants, and you can see how thick the tissue has become. So it really is a demonstration of how we can boost the biotype, and it almost looks like we are looking at a different patient, but this is an enhanced biotype. Just to show you the final result of this patient, I show you the final prosthesis here still sitting on the model. This is the situation you are looking at right now in the mouth of the patient. So a full gold ceramic bridge in upper and lower jaw was placed in this patient on the thick tissue we created with the soft tissue management. Okay, I'm happy to present now the next patient, and this very friendly girl was sitting on the back of the motorcycle of her boyfriend when this boyfriend tried to imitate Valentino Rossi by doing a wheelie. So the wheelie went well, but his girlfriend fell off the cycle, and you can see the damage this crash did to her. One of the lateral incisors was lost shortly after the accident, and the suturing they did in the hospital was not really very well done, as you can see looking at the scar tissue we have on screen right now. So this is not a very nice thing for this girl. Also, on top of that, there was the oral damage, and I had to place an implant into the area of the lateral incisor. So the patient was sent to our office, and this is what I saw when I exposed the defect. You see the enormous damage also on the central incisor. An implant was placed, and you can see that a huge portion of the facial area of the central incisor was exposed. So I had to take bone from the chin with the bone harvester, and with this bone I started doing the build-up. And I placed the implant, which is completely covered by the bone graft now, and I also started to reconstruct the buccal plate with this bone harvested from the chin. So this was a little bit how I built up the area, and everything was covered with a membrane. It's a well-adapted membrane because it nowhere touches the neighbor teeth, and this is the tension-free closure. So by closing the area, we create a mucogingival defect. 8 months later, it was time to remove the membrane, and you can see the lack of keratinized tissue around the central incisor. So this surgery, this first surgery, was planned just to remove the membrane, because in a later stage we plan to rebuild also the biotype. So this happens very frequently, that we rebuild the bone. By rebuilding the bone, we have to mobilize the flap. By mobilizing the flap, we create a mucogingival defect. And then afterwards, when we have the bone and we have the implant, we rebuild also the soft tissue. So we just create the bulk of the tissues first and then start to shape it with a provisional. You see here the removal of a bone tack. This is one of the buccal bone tacks. A membrane has to be stable. You see the membrane is still sitting on the newly formed bone. And this is a moment which we can call the beauty of GBR, because we can really see what we can recreate with this technique. The buccal portion of the membrane has been removed. This is the palatal portion, and we have to be very careful in order to remove the complete membrane. So no pieces can left behind. The palatal bone tack has been removed right now in this moment. Now first the membrane comes out, and then you can see now the bone tack. Here it is. So at this stage everything has been removed. We have to dig now for our implant in the newly formed bone. So bone really grew on top of the implant. I had to use a 3-fine burr in order to uncover the implant. And this is how nicely the area was rebuilt. Also the situation buccally from the central incisor has improved a lot. We just closed the area as it was. The implant was left under the flap, and this is the closure. So the idea was to let this area heal for only 5 weeks, and then after these 5 weeks we would go back into the site and do a partial thickness flap. The partial thickness flap really works best when we want to build up the area with a connective tissue flap, which will we submerge under the mucosa. You can see the missing tissue and the concavity in the area of the root. So we're gonna build up a root contour, and at the same time we're gonna try to rebuild also the missing keratinized tissue on the central incisor. So also for this purpose we make a very precise template. You can see doing me the cutting right here, and we gonna harvest a connective tissue flap with exactly the same shape as the template. So now I start making a perforation to uncover the head of the implant. So this is done with a tissue punch, and the tissue punch, this little circle, should end up right there where the cover screw is. I use the mold curette just to remove this little patch of tissue. Here it goes. The microsurgical instruments, and in this occlusal view under in your screen you can see the concavity we're gonna build up. So the buccal concavity is being inverted with the connective tissue graft into a convexity. So for that purpose I'm preparing a pouch in this area now. So this is the area we're gonna boost with the connective tissue we will bring in later from the palate. Now I would like to go into the area of the central incisor without destroying my papilla. You can see I use the mold curette just to bring some more volume in the pouch. And now we're gonna extend the incision into the area of the central incisor, and we like to do that without cutting through the papilla. So this is why the papilla is beveled palatally, bringing outside the aesthetic area the incision line in this way. And now we extend this incision from the pouch into the sulcular area from the central incisor. So in this way I'm able to prepare a partial thickness flap in exactly the same shape as the template. So without having any vertical incisions into the aesthetic zone. Although the tissue is very thin, with this flap design it was able to do that in a controlled way. We can see now the removal of the cover screw, and I place a healing abutment on the implant. And we leave this side for a moment the way it is. We check the template, and this is what we have to harvest now from the palate. Also here, after giving the anesthesia, I'm probing with my needle to see where we have enough thickness. Unfortunately, the palate is very thin. So also in this case, I had to remove the complete layer by depitalizing the graft while it was still on the palate. So you see here the outlining of the graft, and now I depitalize the graft by scraping off the epithelium. And the epithelium is gone when the bleeding starts. You can also use a diamond drill for this step if you want to. And this is then the removed graft. You can see on the border there's still a tiny strip of epithelium left, and we remove this with the microsurgical scissors or with a very sharp blade. So we have to remove the epithelium because this graft is going to be placed completely under the covering layer, so we don't want epithelium to remain on the graft. This is how we put some collagen on the donor side. We cover it with crossed sutures, and this is the precise shape of the connective tissue, so it's exactly the same as the template. You can see I bring this graft into the site. You see how much thicker the tissue becomes, and I'm looking now for a fixation point. The best thing to do, I found, was to look for a mesial fixation point by applying a suture connecting the different layers, and these 3 layers are connected now by just one suture. And this is how I try to bring in the graft in the pouch and in the partial thickness area. You can see now that when I try to close the flap, a big depression still remains in the area between the lateral and the canine. So this is why I had to take it out again and extend the pouch more distally in order to interconnect the bulk of the canine with the area where I wanted to create the illusion of the root contour for the lateral. So that's buccally from the implant. You can see now, bringing back in the graft, we have a much more harmonious buccal contour. And now, just with a vertical mattress suture, I can cover up the whole graft, and this is bringing also fixation for the graft. With the vertical mattress sutures, I'm placing right now into the beveled papilla. You can see the incision line is out of the aesthetic zone because it's completely palatal. So we have a positive root profile now for the implant interconnecting with the canine. In the next case, we can see the X-ray of a patient where I had to remove the molar due to periodontal problems. There was a bifurcation problem. I had to separate the bridge, and also the mesial extension of the bridge had to be removed. In this area, the first premolar, I intended to place a one-piece implant. And you can see here the area where we are going to place the implant now. You can see that the quality of the bone was not very dense. So the clinical situation, you can still see here the extension before and after the removal. And in this area, we're gonna try to do a flapless placement of the implant, and it's a one-piece implant we're gonna use. Buccal view. In the buccal view, I would like to underline the importance of doing this type of procedure only in cases where you have an abundant amount of soft tissue. You can see the soft tissue still present, and we have a surplus of soft tissue in this area. So even if we get some shrinkage, we still will end up with enough soft tissue. And this is the first drill. And of course you can do this only flapless when you know there's enough bone in the area. In order to find it out, you can make a CT scan, or you can do some bone mapping, as I did in this case. This is the second drill, and you can see how easily this drill goes up right till the bottom of the sinus. So the bone quality is not very high. This is a little device which helps us to guide a tissue punch. With the tissue punch, we're gonna create a circular perforation in the mucosa. My advice is to choose the tissue punch one size smaller than the actual size of the implant you're gonna place. So these come in different sizes, and this is how you can make in a controlled way a perforation. Because we are working with an implant that has an integrated abutment, we can check the direction of the implant and also of the position of the future abutment. So prosthetically, a one-piece implant has to be placed very precisely, because we cannot do any corrections with the abutment. You can see the amount of soft tissue. In order to condense the bone, we have a bone condensing device which can be used to augment the primary stability in this area. It has the same role as an osteotome, and we go from 2 mm to 3, from 3 to 4, and in the end we eventually will place a 4.3 mm implant. Within this set, by squeezing this plastic handle, we can have an idea of what will be our insertion torque when we insert an implant of more or less the same diameter as the device we are using. So the steps were that we went from the 2 mm pilot drill through the bone expanders, and this is how we will place an implant slightly bigger than the last bone expander we used. When we are using one-piece implants, we have to look for primary stability because these implants are meant for immediate function. Irrigation is not used because we want the blood to be the first liquid penetrating into the microporous implant surface. This will help to start up osseointegration faster and in a more complete way. We will do the last couple of turns by hand. So when the implant stops, we will try to stabilize the implant by hand, and we will look for an insertion torque which is at least over 35 Newton. We need this in order to be confident for the immediate function we will apply on this implant. We base the shell of the temporary now with dense acrylic and composite on the margins, which will be polished to high gloss. We will be very careful not to press any of these materials down towards the bone, because we realize we don't have a soft tissue seal yet after just placing the implant. So this is important. Keep the area clean. After an occlusion check, we might have only few actual contacts on the temporary. We go now for a non-cementation protocol. So we don't want to press any cement along the implant into the microporous surface, but we use just a chlorhexidine gel. The gel is applied and refreshed several times in the first couple of weeks in order to avoid cement retention and in order to keep the area clean. At the same time, the patient won't chew too hard on this area because of the danger of the temporary falling off. You can see how nicely the implant is stabilized on the bottom of the sinus. 3 months we have to wait until the soft tissue level is stabilized, and then we can re-prepare the integrated abutment. We create an anti-rotation groove. We make an impression very carefully, and then we are trying in now the golden casting. A porcelain fused to metal crown will be made after checking the fit of the metal. Now you can see how nicely the tissue fits around the integrated abutment and the transmucosal part of the implant, and the final crown is put in place. You can see the quality of the soft tissue seal because we never touched this area after placing the implant. In the distal area where the molar was removed, an extensive GBR procedure combined with a sinus lift had to be performed in order to place an additional implant for the molar. This next patient, a 22-year-old girl, fractured a first upper premolar. This girl refused to stay without the tooth, even for more than 1 day. And you can see here clinically the presence of the fracture. It was a vertical fracture. 1 month went by before this patient was referred to my office. And you can see here from occlusal that the direction of the fracture was oblique through the rotated premolar. On the X-ray, the fracture was invisible and no damage on the bone was evident. By probing, I discovered that there was some clinical damage because in some spots the probing depth was more than normal. You can also see this right now because the blade is going into the fracture defect, which made me decide to raise a flap and in order to have a better view on the damage the fracture did. This is how the area looked like after raising a flap. Some of the granulation tissue was cleared out and the extraction was performed by cutting the tooth in two, and rotational movements were used for extracting the two separated roots. Of course, we realize that we can run a slightly higher risk when we have a presence of bacteria in this area. And you can see how thin the remaining buccal bone was after removing the buccal root. Palatal root was taken out as well with same rotational movements, and the extraction was done. And now we explore the socket, and it really looked if there was a molar before the extraction and not a premolar with only two roots. So we had a lot of damage and a big gap would remain around the implant. The implant was placed in an area slightly palatal, where you see me entering now with the 2 mm pilot drill. The pilot drill went in as deep as possible because I was looking for an area where I could find the primary stability also for this implant. A one-piece implant was selected also for this case. You can see the palatal position of the implant after the preparation. Also here, in this case, we place the implant without irrigation. You can see the blood wetting the microporous implant surface. Also here we went for sufficient primary stability by looking for an insurgent torque over 35 Newton. A safe scraper was used to harvest some bone from the patient that was mixed with some bovine bone chips. And these chips had a small particle size. We spent some time to mix these two components in order to wet all the bone and to have a homogeneous bone graft ready. This bone graft will be placed into the gap between the implant and the very thin buccal bone. We're using condensers of different sizes in order to be sure that the complete gap is filled with the bone graft. You can see here the occlusal view of the area. A slowly resorbable membrane was cut into the right shape, and some additional bone grafting was done buccally of the implant in order to mimic the shape of a root contour in this area. By perforating the buccal bone, the bleeding guarantees that some of the osteogenetic stem cells present in the area will come out of the underlying bone and help us to recreate a new layer of buccal bone. You can see the additional bone graft in this area, and now the complete graft will be covered with a membrane. We can call this a poncho technique. The membrane needs to be adapted, and the system I use for this type of procedures is a mattress suture, which will push the membrane along this curved segment of the mouth against the underlying bone. So this will stabilize the membrane without having to remove any bone tags later on. Mobilizing the flap by a periosteal cut is done just before we close the whole area. 5/0 sutures are used to place the flap tightly around the integrated abutment. Also here a temporary without any occlusal contacts is being placed with the non-cementation protocol. And the patient can go home after the surgery with a temporary, just the way you see her in this shot. You can see on the X-ray that I overfilled the area. Most of the sutures are removed after 9 days, and you can see that the temporary really supports very nicely the existing papilla, etc. So we are preserving the tissue we had. After 3 weeks, we removed the suture which was placed for the membrane fixation. And you can see how few plaque accumulation we have on a monofilament suture of this size. We wait for healing and tissue maturation, but also for new bone formation. See how nicely the papilla has been supported all this time by the temporary. After 6 months, we take an impression after we slightly prepared the integrated abutment, and we try in the metal for the porcelain fused to metal crown. You can see here the final crown after cementation. And on the X-rays we see the beginning, the time of the fracture, the time of surgery, after placement, and after bone remodeling. This is at 6 months. You can see the bone stabilizes around the area of the first thread. And this is the implant under function with the permanent crown. This is the clinical view of the crown. And the occlusal view. And the comparison between the natural first premolar on the other side and the crown placed on the one-piece implant on the side where we started off with the fractured premolar.